The most common cause of shoulder dislocations and instability in adolescents is mostly traumatic, sports-related. And this causes, injuries within the shoulder. So we see particularly a lot of contact athletes, football or soccer, rugby in particular, but many other sports. So they have a traumatic instability. The other type of instability we see in adolescents is what we call the Stanmore type 2 instability. So this is well described by Stanmore in the Ian Bailey-Stanmore triangle. And this is patients that are hypermobile, which happens a lot during adolescence when, because of the hormonal changes, there is more hyperlaxity and looseness in the joints in adolescence. And adolescents are these days doing a lot more sports than in the past. So the Stanmore type 2 instability is where they might have a more minor injury rather than a big injury like a rugby player, and they develop pain, looseness, instability, and recurrent dislocations of the shoulder. So those are the two main groups we see with shoulder instability in adolescents. A dislocation, you'll definitely know, because the shoulder will pop out of joint and your teenager will say the shoulder is popped out of joint. With traumatic ones, they often have to be put back into joint, either on the pitch by their coach or doctor, or have to go to hospital to have it put back to joint. With those type 2 hypermobile instabilities, it's a bit more subtle. They may get clicking, clunking pain rather than true dislocations. They often may or will say it feels loose or it feels like it's moving more in the joint, and that's signs of instability. You can get the so-called voluntary instabilities where people will pop their shoulder out and pop it back as a party trick, but that is not a pathology. That is a party trick. It depends on the type of instability and dislocations, as we mentioned above. So for traumatic dislocations, initially, definitely see physiotherapist, doctor, A&E is where they'll start out. You then want to know exactly what is the damage caused in the shoulder. And the best scans would be an MRI scan, or if it's chronic, an MR arthrogram where you inject dye in the shoulder. This will give us an idea of what damage there is in the shoulder and what degree of damage there is. So the higher the degrees of damage, the higher the functional demands, sporting demands of the patient are, the more likely that surgery will be indicated to get them back to that level of sport and activities. So this would be, for example, say your academy rugby or football player who has a traumatic dislocation, has big tears of the labrum, the lining of the joint, and dent in the bone, a Hill-Sachs lesion, and their intentions are to go on to have a career in sport. Therefore, surgery would be a more likely beneficial treatment because the risk of recurrence is significantly less. For the type 2 instabilities, again, I would generally recommend doing an MR or MR arthrogram, but the primary treatment for those will be the right sort of rehabilitation. Because we know 2/3 of your stability of your shoulder comes from your muscles, particularly the small muscles in your shoulder. We know that by developing and strengthening those muscles and the nerve linkages with those muscles, called proprioception, the majority of patients should do very well without requiring any surgical intervention. There may be a role of surgery for those patients, but it needs to be done within a multidisciplinary specialist shoulder service. So after a dislocation, it's generally important to see a specialist if you are a high-level athlete, get investigations, and discuss the treatment options. If the options are to go a non-operative route and a rehab route, there is a chance, pending no major structural injuries, to return to sport within weeks. What's really important is that that's done in a very supervised way with very clear targets, goals, and very specific sport-specific tests to make sure those targets are fully achieved before returning back to sports. So those will be the specific lab-based tests. A common one is known as the ASH test, which is well recognized and well researched. But others include, things like fatigability, strength testing, and proprioception, as well as taking repetitive trauma to that area which is sport specific and building into what is specific for that particular sport and athlete at the time. So hopefully, all being well, particularly for in-season type dislocations, they may return back in weeks. I'd normally say, with these athletes, if you are not seeing substantive improvements by about 3 weeks, then we need to revisit the surgical option. In terms of surgery, the rehabilitation time also depends on the sports and the demands of the patient. With younger patients, we got to think long term. And I don't like to rush patients. I don't like the term accelerated rehab, even though we used it many years ago ourselves. The rehab and the recovery has to be what is right for that particular patient. So it has to be customized and correct for that patient. So on average, and this is the group we've done the majority of research on for rugby player or adolescent rugby player after surgery, return to rugby is approximately on average about 4 months. But it could be longer, could be sooner, depending on multiple factors. For a footballer, outfield player, that might be earlier. For a goalkeeper, it might be longer. For an overhead throwing athlete, particularly in the adolescent age, it would definitely generally be more than 6 months because you've got to regain a significantly better range of movement and sport-specific function for those repetitive sports.